Hello, my name is Jennifer Chung. I'm a cardiac surgeon, aortic surgeon at Toronto General Hospital, and I'd like to thank the CCS for inviting me to participate in this year's cardiac surgery trainee review program. The topic I was given was aortic root and arch aneurysms. I'm going to start by giving you guys a list of resources that I think would be useful in preparation for your exam, and then go through 3 cases, one featuring the aortic root, the second featuring the ascending aorta, and then the third featuring the aortic arch. So here's a list of resources. It's important to familiarize yourself with the guidelines. So importantly, the ACC/AHA guidelines from 2010 as well as the 2014 update, the European guidelines, STS guidelines, and do not forget that CCS also has guidelines that are very well written and easy to read. On top of that, you should of course read whatever textbook you're reading and the appropriate chapters. So let's get started with the first case. This is a 50-year-old female with no past medical history. She presented with atypical chest pain, and the following was picked up on workup. Here we have a slice of the coronal series. This you can see was a CTPE, but the arterial system was well illuminated, and you can clearly identify the abnormality. So I would definitely familiarize yourself with CT scans and how to read them, and with every aortic case that you're involved in, definitely, obviously, review the scan ahead of time. This is the patient's transthoracic echo. This is the parasternal long axis view. You can see that the heart function is normal. Once again, you see the aortic root aneurysm that you saw on the CT scan, and the aortic valve leaflets here look nice, thin, and pliable. So what else do you want to know about her? For your oral, it's important to have a recipe in your mind of how you want to conduct your history. And then you take that formula and you tailor it depending on the scenario. And so for the aortic patient you get, and specifically the aortic root patient that you get, are there any special questions that you would like to ask? You have to ask about family history. So it turns out that she has a sister who required emergency aortic surgery, who then needed a second aortic surgery and suffered paraplegia, so likely a thoracoabdominal surgery. On review of systems, that's the second area that you like to ask, a head-to-toe connective tissue checklist. You find out that she's 5'5" only, but she does have marked arachnodactyly and a pectus carinatum. So she saw her genetic counselor and she received genetic testing. She was indeed positive for the FBN1 mutation. So the FBN1 mutation is associated with Marfan syndrome. So what is the Ghent criteria? You can find details about the Ghent criteria on the Marfan Foundation website. I think it's fair game for the exam, and I think it's important for you to be able to list at least some of the findings that contribute to the systemic score. So just to go over it very quickly, in the absence of family history, we're looking for aortic root dilation, Z-score over 2, and ectopia lentis, or the Z-score greater than 2 and the FBN1 mutation, and this she has, aortic root dilation, Z-score over 2 and the systemic score over 7, ectopia lenses, and FBN1 mutation associated with aortic root dilation. And in the presence of family history, which she also has, ectopia lentis and a family history of Marfan syndrome equals Marfan. a systemic score greater than 7, and Marfan, a family history of Marfan syndrome also equals Marfan, and then the root dilation over 2 Z score when you're above 20, over 3 if you're below 20, plus the family history is what would make you diagnose the patient with Marfan syndrome. Our patient has a 50 millimeter aneurysm. So does she have an indication for repair? Yes, she does. So for Marfan syndrome, above the cutoff of 50, we generally offer repair. And so what type of surgery should she get? Data from the Toronto group show that valve-sparing root replacement has better long-term outcomes compared with valve prosthetic or mechanical Bentall. So the green line is the valve-sparing root replacement, and you can see that the all-cause mortality over time is less than the blue and the red line, which is for mechanical and bio-Bentall. On the right-hand side, you can see the cumulative incident rate of major adverse valve-related events, and that is also less for the green line, which represents valve-sparing root replacement, than it is for bioprosthetic or mechanical Bentall. So Dr. David has shown excellent long-term freedom from reoperation and freedom from aortic valve regurgitation over a very long follow-up period. It's important for the Marfan and connective tissue population to stabilize the aortic annulus, and that's what is achieved with reimplantation. If you choose to, say, remodeling during the exam, you must have some sort of annular stabilization technique as well. So indeed, I performed a valve-sparing root replacement reimplantation technique for this young lady with Marfan syndrome with good results. So here's a twist for you. Instead of Marfan syndrome, say the patient had bicuspid aortic valve disease. At 50 millimeters, is there still an indication for repair? According to the Canadian guidelines, you can see here under the aortic root column, for patients with Marfan syndrome, the cutoff is 5 centimeters, but for bicuspid aortic valve disease, it's a range, it's 5 to 5.5 centimeters. The European guidelines further clarify this range. So for patients with bicuspid aortic valve disease and a maximal aortic diameter greater than or equal to 55, then there's an indication for surgery. The threshold is lowered to 50 if the patient has additional risk factors such as family history, systemic hypertension, coarctation of the aorta, or rapid growth of the aorta. So these ideas are echoed in the American guidelines. The threshold for operative intervention for patients with bicuspid aortic valve disease is the same as for patients with tricuspid aortic valves. It's 55 millimeters, that's class 1. You may lower the threshold to 50 if there are additional risk factors for aortic dissection. The reason the cutoff value is actually the same is although patients with bicuspid aortic valves have a higher risk of aortic dissection than the general population, it's about 8 times higher, the rate is still very, very low, and the feeling is that the 5 centimeter cutoff stated in previous versions of the guidelines is too aggressive. And now for our second case. This is a 29-year-old female with an incidental finding of a 60 millimeter ascending aortic aneurysm. So that's her CT scan on the right, and there are a few findings that are very notable. One is she's 29 and she is riddled with calcium across her aorta. And then the second finding is you can see how abnormally narrow the left common carotid artery is. And you can see this narrowing again in the descending thoracic aorta. So what is your differential diagnosis? So during your oral exam, it's important to list a wide range of differential. Even if you have a primary diagnosis or a most likely diagnosis, it's still worthwhile to, for instance, in this case, to list the connective tissue diseases, all the inflammatory diseases, Behçet's, Cogan's, Takayasu, that you can list, infectious, post-radiation. You should have a nice differential available for ascending aortic aneurysms, and then you can perhaps offer what you think is the most likely cause in her case. And would you order any additional tests? For sure, you would get ECG echo like you would on other cardiac patients. You can get a coronary angiogram. You can also get labs, and for this patient, beyond the basic lab work, you should also order ESR-CRP. So what is the management of Takayasu's arteritis? The point of this case is that there's also a medical management side to treating these aneurysms. It's a good idea to get rheumatology involved, and they will often start the patient on high-dose steroids. It's good to settle down the inflammation before heading into your surgery, and they often need ongoing steroid therapy even after your surgery. So what if the patient was 61 years old? Does that change your diagnosis? So this is another real patient. The difference in anatomy you can see here is that she also has a descending thoracic aortic aneurysm. So during your repair, you wouldn't just address the ascending and proximal arch, you would also extend your repair to set yourself up. This woman received a total arch and frozen elephant trunk repair. So the older woman had Giantcell arteritis. So the age shift from under 40 to over 50 is how we would differentiate between the two. And indeed, these two entities, Takayasu arteritis and Giantcell arteritis, very likely represents one spectrum of disease. I also wanted to point out that for Takayasu arteritis, this combination of stenoses and aneurysms is a characteristic finding. And this is what we saw for our young lady in our second case. So on to the third case. This is a 59-year-old man with no previous relevant medical history. His chest pain started at 3 p.m. He presented to the hospital at 9 p.m. and he was extremely acidotic. He had an altered mental status, abdo pain, hyperglycemia. The emergency physicians started him on a DKA protocol. And by 2 a.m. his mental status cleared and he was in severe pain from his right leg, which was pale and pulseless. They sent him to the scanner at that point. His lactate was already 12, his creatinine was elevated, his other labs were okay. These are axial slices from his CT scan. So upper left, you can, I want you to notice that there is a very important primary intimal tear in the distal arch proximal descending thoracic aorta. You can see on the upper right that there's a clear dissection in the ascending and descending aorta. The bottom left shows a sizable pericardial effusion, and then on the bottom right, you can see that the right common iliac artery is obliterated. So this is a challenging case. He has altered mental status, lactic acidosis, pericardial effusion, not stable, ischemic leg, and distal arch proximal descending, primary intimal tear, and obviously the aortic dissection. So how will you manage the situation? A follow-up question to that is, what are the indications for extended arch replacement during repair of an aortic dissection? The Canadian Thoracic Aortic Collaborative addressed this question in this state-of-the-art review in the Canadian Journal of Cardiology in 2016. So the review suggests considering an extended distal repair if there's evidence of a distal malperfusion, presence of primary intimal tear in the distal arch or descending thoracic aorta, young patients, and patients with dilated arches and descending thoracic aortas. So for this patient with the distal arch tear as well as the distal malperfusion, I didn't just replace the ascending aorta and the proximal arch, the entire arch was replaced. And you see here in this axial slice, the frozen elephant trunk that I used to cover up that primary intimal tear. As for what we did with the leg, because it had been ischemic for a good duration of time before I could get the patient into the operating room, I had called vascular surgery to join me so that they can simultaneously do a fem-fem crossover, and that's allowed immediate reperfusion to that leg and didn't need to wait for me to complete the arch repair before that malperfusion could be resolved. At the end of the case, we reassessed the leg, and he received fasciotomies before we left the OR. So his hospital stay was longer, but he actually did quite well, and I still follow him in dissection clinic. And yes, indeed, he is walking and doing well. Follow-up question: list strategies for brain protection during arch surgery. So there are intraoperative cerebral monitoring strategies that we can employ, and they include NIRS and Bis monitoring. Temperature management is, of course, very important. And how are you going to cannulate and how are you going to manage cerebral perfusion during arch repair is critical. NIRS is near-infrared spectroscopy. It measures regional cerebral oxygen saturation. So these are the stickers that are on the patient's forehead. If one side drops, it can be useful in identifying kinks in your line or thrombosis of grafts and dissection to vessels. Unfortunately, despite its wide use, and I do use NIRS, there's poor evidence for it, and there's no evidence that it alters the outcome. So if you are going to use it, it's important to understand the limitations. It is placement dependent. The penetration is not deep into cerebral tissue. It's on the order of centimeters. And there's no universal definition on what a significant decrease means from baseline. So it's important to know that NIRS actually increases when you cool. During circ arrest, you may see a decrease in your NIRS. If you do antegrade cerebral perfusion, hopefully you would see minimal decrease. And if you see a unilateral decrease, say on the left side, that may be indication to clamp that left common carotid or perfuse that left common carotid. So another technique is Bis monitoring. This is a single lead EEG. 0 means that the patient is completely comatose and 100 is a fully awake patient. It's used for monitoring depth of anesthesia, and it's been adapted for deep hypothermic circ arrest. There's a linear relationship with temperature, and it decreases to 0 for most patients at 17 degrees and for virtually all if it's under 10 degrees. The length of time it takes to recover your Bis monitoring is related to the length of time of deep hypothermic circulatory arrest. So, of course, there are some limitations. Like with NIRS, the benefit has not been proven. There are some issues with electrical interference in the operating room, and importantly, we don't often use a deep hypothermic circ arrest, but instead, nowadays, it's usually hypothermic circulatory arrest with cerebral perfusion. How do you choose between normothermia, moderate hypothermia, and deep hypothermia? Well, the temperature chosen affects the safe duration of total circulatory arrest time. So with every 10-degree drop in temperature, you get a approximately 2-fold decrease in your metabolic rate. So the deeper your hypothermia, the longer the duration of safe total circulatory arrest time. But I want to emphasize that that is total circulatory arrest time. With the addition of cerebral perfusion, you can actually lengthen the duration of safe systemic circulatory arrest time. There is indeed evidence that by using ACP at moderate hypothermia, even for longer than 30 minutes, you can have better long-term outcomes than with deep hypothermic circulatory arrest with no cerebral perfusion. The next question is, where are you measuring your temperature? The nasopharyngeal temperature is the most reflective of your brain, but I also use a rectal temperature probe. You can also use bladder temperature, and these peripheral measurements are more reflective of your body temperature. So this is a good way of ensuring that your body is not too warm when you start your circ arrest, and also that your body has sufficiently rewarmed when you come off bypass, so that you don't have too big of an after drop. In terms of cerebral perfusion techniques, there are 2 main categories. That's antegrade cerebral perfusion, whether unilateral or bilateral, and retrograde cerebral perfusion. So how will you institute the perfusion strategy? So during your oral, I would describe techniques that you've seen and are very familiar with. So are you going to cannulate the axillary artery and clamp the innominate artery and perfuse the brain antegrade that way? Or are you going to cannulate the innominate artery directly? Are you going to do that by sewing on a graft? Or are you going to cannulate it with a separate cannula? Are you going to also put a balloon in the left? Or how are you going to set up your lines? If you're doing retrograde, is it with what type of cannula? Are you putting in the SVC and so on? You should be familiar with the purported benefits and downsides to either technique. So with antegrade cerebral perfusion, it's essentially like staying on bypass to your brain, and so it's providing nutritive flow. The safe duration of circ arrest can be greater than 40 minutes. You can repair the arch safely, keeping in mind that unless you're doing additional perfusion techniques, the rest of the body is, of course, ischemic. There is, however, more manipulation of the arch branches, and if you're doing axillary cut downs, that's also additional time. On the other hand, with retrograde cerebral perfusion, you get even cooling through the veins. It flushes out air and debris, and the SVC is right there. Unfortunately, there's minimal nutritive flow to brain tissue, so it's unlikely to provide as long a safe circ arrest time as with ACP. So during your oral exam, if you've chosen one of these techniques, you have to be prepared to describe it in detail. So what flow rate are you using? What pressure are you aiming for? What temperature? These sorts of questions. So for ACP, typical flow rates are 10 to 12 mils per kilo per minute at 40 to 60 millimeters of mercury. Now, if you're using the right axillary artery for ACP, then you often overperfuse the right arm. So your right radial pressure is actually not reflective of your brain pressure. So it's a good idea to snare the axillary distally and equalize the blood pressures between the right radial and your either left radial or femoral art line prior to circ arrest. So what temperature? Well, it's going to be your circ arrest temperature. So if you chose, say, 24 degrees Celsius, then once you've clamped that innominate artery and dropped your flows, you're essentially pumping at your circ arrest temperature. So what about retrograde cerebral perfusion? The typical flow rate there is 200 to 300 mils per minute, and the pressure you're looking for is 25 millimeters of mercury. You don't want it too high to avoid cerebral edema. There is also this concept of an opening pressure first prior to dropping down to 25 millimeters of mercury. I also want to touch on PHDap versus Alphastat. So this is a favorite exam question. The idea is that as you cool, CO2 becomes more soluble in the blood and causes increased alkalinity of your blood. If you're using the PHDap strategy, then you would add CO2 as you cool to counteract this effect and maintain a neutral pH. This causes cerebral vasodilation, which leads to more cerebral blood flow and better cooling. On the other hand, if you use the Alphastat strategy, then you accept the increased alkalinity as you cool. This allows your brain to do its own cerebral autoregulation in terms of vasal dilation and constriction, and it maintains cellular and protein function better. For adult cardiac surgery, Alphastat is actually the way to go. It may not be a good idea to have more perfusion to the brain. That can actually lead to more thromboembolism, and maintaining your own cerebral regulation is actually better. On the other hand, PHDap strategy has actually been shown to be better in the pediatric patient population. So that's it from me. I want to leave you guys with some tips. So of course, memorize your guidelines, but also apply them at work regularly. So with every aortic case that you get, work through it, develop your own plan beforehand, and then bug your attendings and perfusionists. It's a lot easier to consolidate your readings through regular workout use than through brute force memorization. So good luck to all of you on your exams.